Hello, everyone, and welcome to another episode of SLP Grad Girls. We're your grad school hosts, Jenna.
And this is Madeline. Today we're taking a deeper dive into the motor speech world of dysarthrias. And we have a very special guest on later to tell you about assessments and intervention approaches.
Awesome. Can't wait. Let's begin. Madeline, I'm going to say what we are all thinking. What exactly is dysarthria again? And as a grad student, have you taken a course in it yet?
I know, the world of speech-language pathology is very broad, and we sometimes need a refresher to get our brains kick-started. Yes, I am currently in a motor speech class learning all there is associated with motor speech disorders, and dysarthria is a major component of all of that. So, motor speech is defined as speech disorders resulting from a neurologic impairments affecting the planning, programming, control, and execution of speech. This is straight from a major name in the game, Dr. Joseph Duffy, whose focus has been motor speech disorders for quite some time.
That's right, and this includes dysarthria and apraxia.
Correct. Dysarthria is a speech disorder caused by muscle weakness. It can make it hard for you to talk. People may have trouble understanding what you say. So ASHA says dysarthria happens when you have a weak muscle due to brain damage. It can be mild or severe.
Yes, it's ringing a bell now. There are 6 major types of dysarthria. This includes flaccid, spastic, ataxic, hypokinetic, hyperkinetic, and mixed. There's also unilateral upper motor neuron and an undetermined category.
Undetermined?
Yes. In Duffy, it says that undetermined is when it is recognized as a dysarthria, but is complicated and unusual. The clinician is able to rule out what the dysarthria is not. There is a perceptual method for classifying MSDs that was developed by Darley, Arnson, and Brown. This helps in the diagnosis and management. While some reflect an etiologic and neurologic approach, others are linked to specifically the signs and symptoms of the speech disorder themselves. This includes the age of onset, whether it's acquired or congenital, the course, the site of lesion, neurologic diagnosis, and pathophysiology. Establishing a lesion site can predict certain speech deficits.
So under those 6 different dysarthrias, each of them have different localizations.
Where are they at?
So for flaccid dysarthria, it is under the final common pathway, which means a person may have difficulties with execution. Then spastic dysarthria is under the direct and indirect pathway, which means again it will affect the execution of a patient. There is also unilateral upper motor neuron dysarthria that affects the direct and indirect pathway, but it impacts execution and control in a patient.
Wow, so there are multiples that affect execution. What about hypokinetic, hyperkinetic, and ataxic dysarthria?
Yes. So hyperkinetic and hypokinetic are both under the basal ganglia control circuit, which means control will be impacted. Then the final one is ataxic dysarthria, which is under the cerebellar control circuit and also impacts control.
Well, now we know all about the localizations of these dysarthrias, but how about the etiologies? Let's start with flaccid.
So flaccid dysarthria is going to be caused by damage to the motor unit. These causes varies due to the function of a particular cranial or spinal nerves involved. Degenerative diseases are the most common. The Mayo Clinic study from 2009 to 2016 listed tumors, vascular, neuromuscular junction disease, muscle disease, trauma/surgical, demyelinating, infectious or inflammatory, or other. This study found 18% to be an undetermined diagnosis.
Moving next into spastic and ataxic, spastic is frequently associated with degenerative vascular disorders, congenital, traumatic, inflammatory, and toxic and metabolic diseases. Degenerative and vascular are the predominant causes. Ataxic dysarthria is affecting that cerebellar control circuit that Madeline spoke about earlier. The most frequent causes are degenerative, vascular, traumatic, and demyelinating.
Then we have hypokinetic and hyperkinetic. Hypokinetic interferes with the basal ganglia control circuit, and the etiologies are degenerative disease, vascular conditions, toxic metabolic conditions, trauma, and infectious conditions. Then hyperkinetic interferes with the basal ganglia control circuit, and the etiologies are unknown, but mainly degenerative diseases, toxic metabolic conditions, infectious conditions, trauma, neoplastic, and inflammatory conditions are all known possible causes.
Lastly, we'll discuss etiology of unilateral upper motor neuron. This dysarthria affects the upper motor neuron and is normally associated with vascular disorders, tumors, specifically brain tumors, and trauma.
This has been a great discussion so far, and a refresher for all of us, I'm sure. Before our special guest comes in, I wanted to discuss the neuropathophysiologies real quick for each dysarthria that I've learned in class.
Yes, great idea. Share the knowledge.
So, flaccid dysarthria is weakness with decreased tone. Spastic is spasticity and increased tone. Then, ataxic dysarthria is incoordination. Hypokinetic is rigidity and reduced range of motion. Then hyperkinetic is involuntary movements which are dystonia, chorea, athotesis, myoclonus, tremor, tics, bullismus, and spasm. Then finally, unilateral upper motor neuron is a combination of weakness, spasticity, and incoordination.
We'd now like to welcome our guest, Dr. Ivana Talk, who works as a professor at Harvard's Speech and Hearing Bioscience and Technology Department and has over 30 years' experience working with motor speech disorders. Welcome to the podcast and our special dysarthria episode.
Yes, happy to be here, and thanks for having me.
We know a lot of your work has been working in the field of dysarthrias, and for us grad students, it can be so hard to separate them from one another. Can you tell us how you assess?
Of course. First and foremost, I think it's important to note that the diagnostic statements that a clinician makes are always based on their findings from their exams and what they could see from their patient and what they could hear from their patient. If these findings are ascertained in an objective way, they can help validate the nature and the severity of an MSD and help a multidisciplinary team consider different methods to manage the condition. Patient history is essential to accumulate because it often provides the onset of the symptoms and the course that a patient has experienced these symptoms, as well as patient complaints and any other indications that can assist a clinician with that diagnosis. Often, a patient interview can also act as a connected speech sample, which is very important to get because it identifies the functioning of speech symptoms. Including articulation function, phonology, respiratory, resonance, and prosody functions.
So wait, can the grandfather passage be used as a connected speech sample?
I don't think I'm familiar with this.
The grandfather passage is a reading passage with 116 words and every kind of speech sound. A normal speaker should take about 35 to 55 seconds to read. Salient speech features are also important to look for when assessing. These include speed, strength, range, steadiness, tone, and accuracy. And they really help identify where the symptoms are localized. An example, steadiness is often associated with the control of movements. So if a person has issues with steadiness and accuracy, they may have issues with control, which could indicate a dysarthria that is associated with the control circuit pathway, such as an ataxic dysarthria associated with the cerebellar circuit, or a hypokinetic or hyperkinetic dysarthria, which is associated with the basal ganglia control circuit. An oral mech exam should always be done and is a great tool when identifying non-speech characteristics, as well as functioning of the speech subsystems. It is also an integral piece in differential diagnosis. An example, fasciculations on the cheeks and or tongue are a sign of cranial nerve or spinal nerve damage, which is an indicator of flaccid dysarthria because it's the only dysarthria concerning the cranial and spinal nerves. An oral mech can also identify if certain reflexes are present or absent, such as the sucking reflex, snout reflex, gag reflex, palamomental reflex, and jocclunis, which indicates that a patient may have a dysarthria that is localized within the direct-indirect pathway, such as a spastic or unilateral upper motor neuron dysarthria. AMRs and SMRs are beneficial when looking at differential diagnosis for spastic, ataxic, hypokinetic, and hyperkinetic dysarthria, as they differ based on speed and coordination across the different types of dysarthrias.
This is a lot of interesting information, especially for us grad beginners. I do need a reminder of what those AMRs and SMRs are again.
Oh, of course. Yes, your AMR stands for alternating motion rate. This is a single syllable being repeated at a maximum rate, such as pa-pa-pa-pa. Your SMR are sequential motion rate, and this is a sequence of syllables repeated at a maximum rate, such as patika. The two traditional tests of oral diakinesis are common in assessing motor speech production.
Yes, I vividly remember the SMRs and AMRs from class. I also remember something about vowel prolongations.
Yes, vowel prolongations are a useful tool in assessing the respiratory and phonatory coordination. It can also help identify neuropathophysiologies, like the presence of weakness in a flaccid or a spastic dysarthria.
We've learned a little bit about how you assess. Is there a specific dysarthria you've researched more than another, and can you tell us a little about it?
Well, I actually brought a case study to review with you, and I think we should try to play a little game and see if you can guess which dysarthria this patient would be diagnosed with. So, here is the case. A 71-year-old woman presented to the ear, nose, and throat department, or the ENT department, with a 3-month history of lost voice. Her medical history was unremarkable, and the only abnormality on the ENT examination was decreased tongue mobility. Neurologic dysphonia and possible LMN disease were suspected, and speech pathology and neurology consultations were arranged. During speech evaluation, she recalled that her progressing speech difficulty had been present for about 15 months. She complained that her voice was strained and that her speech was slow and effortful. She occasionally choked on liquids and had infrequent nasal regurgitation, and she had not had to modify her diet, but she also hasn't lost any weight. She denied change or difficulty controlling emotional expression, drooling, or any problems with memory or other cognitive skills. Her speech AMRs of the jaw and the lower face and the tongue were all slow but regular. Jaw and lower face strength were normal, and the tongue was equivocally weak. There was a slight droop at the right corner of the mouth and a subtle snarl of the left upper lip at rest. The palate was symmetric and moved a little during the vowel prolongation, but it moved normally during the elicited gag. Her cough was normal. I do have a little clip of this patient. Let me play it here for you.
Now on this one, I'd like you to take in a deep breath and go pop, 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 fast and steady, please.
Pop, 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 pop.
Next one. Ta 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 ta, fast and steady.
Ta 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 ta.
Cut, 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 fast and steady.
Cut, 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 cut.
Okay, any ideas of what you think this could be?
Hearing this case and this sound clip, this is tough. Madeline?
I think I'm going to go with spastic dysarthria.
Yes, Madeline, it is spastic dysarthria. And based on what you heard, it is probably a moderately severe spastic dysarthria. The speech characteristics are strongly suggestive of a bilateral UMN dysfunction affecting the bulbar musculature. The patient was referred for speech therapy and management for her dysphagia.
Well, it's been great having you here to talk, Dr. Ivana Talk. I feel like we could talk all day about this stuff. Thank you.
Yes, it's been really great and inspiring to hear all about your experience.
Thank you for having me.
Stay tuned for next week when we dive into apraxia of speech across different populations.
We will have a special guest, President of Michigan Speech Language Hearing Association, Dr. Rosalind Davis.
Until next time, we're your SLP grad girls.